A very good morning to everyone. I am Dr. Garima, reader in the Department of Oral and Maxillofacial Pathology. So I'll be starting with the topic shedding of teeth. These are the contents which I'll be dealing with: shedding of teeth, the pattern of shedding, histology of shedding, mechanism of resorption and shedding, clinical consideration, conclusion. So what is shedding? The physiologic process resulting in the elimination of the deciduous dentition is called shedding or exfoliation. The main factors which play key role in shedding of teeth are odontoclast and pressure from the successional tooth. The pattern of shedding. Shedding occurs as a result of progressive resorption of roots of the teeth and their supporting tissue, that is the periodontal ligament. In general, the pressure generated by the growing and erupting permanent tooth dictates the pattern of deciduous tooth resorption. At first, the pressure is directed against the vestibular direction. Resorption of the root of the deciduous incisors and canines begin on their lingual surfaces. So, if we see the pattern of shedding, the resorption of roots of primary teeth starts at the lingual apical areas in the anterior teeth and in interradicular areas of posterior teeth, that is molars. In anterior teeth, you can see the pattern of resorption. It occurs on the lingual side. First, the pressure causes crypt wall resorption, and then the resorption of root occurs linguoapically. Later, the developing permanent tooth germ, they occupy the position which is apical to the deciduous tooth, which permits them to erupt in the position formerly occupied by the deciduous tooth. However, frequently this apical positioning of the permanent tooth germ does not occur, particularly in the case of permanent mandibular incisors, where the permanent ones erupt lingual to the still functioning deciduous incisors. So now if we come for the posterior teeth, that is molars, first the resorption of the roots of the deciduous molars, they often begin on their inner surface facing the interradicular septum, and this early resorption occurs long before shedding of deciduous molars. As a result, which is seen here, as a result of continued growth of the jaw and occlusal movement of the deciduous molars, the premolar tooth germ come to the apical to the deciduous molars. And this change in position, it provides the growing premolars adequate space for their continued growth, and also it relieves the pressure on the roots of the overlying deciduous molars. Later, when the premolars they begin to erupt, root resorption of the deciduous molars is again initiated and continued until the roots are completely resorbed. The resorption may even proceed far up to the coronal dentine, and occasionally some areas of the enamel may be destroyed, as it is seen in the picture. Now coming to the histology of shedding, the fact that programmed cell death is seen during shedding that occurs at specific ages is consistent with the concept that shedding is a genetically determined process. Resorption of hard dental tissues. The resorption of the hard dental tissues of deciduous teeth is achieved by highly specialized multinucleated cells which are called as odontoclasts. Because of their involvement in the removal of dental tissues, and these cells are quite identical to the odontoclasts. The periodontal ligament cells in the teeth, they undergo shedding and they express rank L. This Rankel expression is linked to odontoclast formation and activation of the shedding process. This pulp, it does not contribute to the process of shedding, and it plays a passive role in the whole process. Resorption predominates over repair. This repair is achieved by cells resembling cementoblasts that lay down a dense collagenous matrix in which spotty mineralization occurs. Resorbed enamel and dentinal surface, they become coated with cellular cementum like tissue which is secreted by mononuclear cells. This formation of cementum like tissue plays an important role in retention of deciduous teeth until shedding occurs. Now coming to the mechanism of resorption and shedding. The pressure from the erupting successional tooth and appearance of odontoclasts at the site of pressure and this membrane of ruffled borders, they act as proton pump which adds hydrogen ions to extracellular region leading to acidification and finally mineral dissolution. Increased forces of mastication with increase in jaw size, they lead to trauma to periodontal ligament, finally leading to degeneration of periodontal ligaments. Now clinical consideration, there are two types of clinical consideration teeth, you can see natal and neonatal. So the difference between natal teeth is the tooth which is already present at the time of birth and neonatal tooth which comes in the oral cavity within 30 days of birth. Eruption cyst, the follicular enlargement occurring just before eruption and usually it is blue-black in color due to the presence of blood which is seen in the picture. Ankylosed tooth and submerged tooth. So ankylosed tooth is when the tooth is attached directly to the bone without presence of any periodontal ligaments. Whereas submerged tooth, as it is seen in the picture, the tooth is already erupted into the oral cavity but it is just below the occlusal surface or occlusal surface of the other teeth. In this you can see submerged second primary molar. Impaction. Due to the failure in eruption mechanism, this impaction occurs. Most commonly, impaction can be seen in maxillary canine and third molars. Remnants of deciduous teeth. Sometimes segment of the roots of deciduous teeth, they are not in the path of erupting successors and may escape resorption. These fragments are most frequently found in the region of premolars, especially in the lower second premolars. The reason is that the roots of the lower second molars are widely divergent as it is seen and the mesiodistal diameter of the second premolar is much smaller than the greatest distance between the roots of the deciduous molars. Now deciduous teeth which is retained in the oral cavity. This teeth may be retained for a long time beyond their usual shedding schedule. Retention may be due to local or systemic causes and congenital absence and impaction of the permanent successors are the common cause for this type of retention. So, coming to the conclusion, for the clinicians to treat dental problems, knowledge of proper eruption and shedding time is very important. A variety of developmental defects that are evident after eruption and shedding of the primary and permanent teeth can be related to local and systemic factors. Thank you.